This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. She's an 85-year-old lady who has pseudoexfoliation and a grade 5 brown rock-hard cataract. The pupil is moderately dilating. I am beginning the surgery by injecting 1.5 ml of xylocaine in the posterior subtenance area so that it gives a better analgesia. And because the surgery is going to take some time, I thought I'll just give this subtenance injection. To begin with, it wasn't looking very scary, but over the period of time, I realized that this was one of the more tougher cases which I've done of late. And as I'm doing the case, I'll share you the thoughts which are going in my head at that time. What were the right decisions? What were the not so right decisions? I'll just tell you. As I begin the surgery, at this point, the plan was very simple. I wanted to use a pupil expansion device, that's a BHEX pupil expansion device, which is my usual go-to device, and then try to do a bigger excess. I expect some zonular weakness because of pseudoexfoliation as well. And my initial strategy was to do a stop and chop technique in this case. Because I knew that the nucleus was hard and I had to break the central core of the nucleus. I thought stop and chop would be much more safer in this eye, and let's see how plans do change while you're doing surgery. So I had given a very strong thought on whether to do an SICS itself in this patient because I thought the pupil is not very well dilating. Why to take the risk? And I argued in my head whether to go in for SICS or phaco, and somehow I chose phaco, but at that point I was really not convinced, but I had taken the decision to do phaco, and let's see how things turn out. The side ports are done, capsule is stained. Incision, I'm consciously making a scleral incision. This is a sclerocorneal tunnel incision. The idea is in the situation where I would want to abandon the phaco, I would like to use the same scleral tunnel to extend and to extract out the nuclear fragments if the situation demands. That's the idea. So I have a nicely constructed sclerocorneal incision, which is maybe a little bit long, but will be perfectly fine for managing. The BX ring is placed into the eye. And the one complaint which I have, and I have also passed it on to Dr. Suvain, who is the creator of this device, that the color of the BX ring is exactly the same as the Indian iris. It is brown. And sometimes when we are dealing with not so clear corneas who have thicker arcus, it is difficult for us to visualize this, the flanges, so that we can hold it. So that is one small issue which I have had with this device. But this continues to be our favorite device for many reasons which we have discussed in many of our previous videos. Nevertheless, all the notches are in place. Time to do the rhexis. Now, as I begin my rhexis, I'm very much conscious to observe whether there are any wrinkling once I touch the capsule. As I touch the capsule, there is some wrinkling, but I could perforate the capsule. And as I'm trying to grasp this flap, there is a little wobbliness of the lens, suggesting that the zonules are not really in great health. And as I'm trying to tear it, the rhexis margin in some places going under the pupil, I'm not able to visualize the wrinkling which we see at the edge of the tear. But nevertheless, because the tearing was not so difficult, I assume that the zonules are not very bad. As I'm tearing, I'm very conscious that the rhexis size has to be at least 5.5 mm or larger than that. It's very important to realize that when you're doing hydrodissection, we need to be very careful not to use more fluid. Couple of droplets of fluid that's all is required to pass it across the subcapsular zone and under the nucleus. Because remember, there is no space and invariably the capsule is very thin. Just trying to nudge on the nucleus and to see whether it's moving freely. So once it's done, time to manage the nucleus. Before that, again, OVD is being replenished into the eye. Remember that endothelium is always priceless. Since I've decided that I'm going with phacoemulsification, it's my responsibility to ensure that the endothelium is maintained absolutely safe. Just confirming the nucleus rotation, it's fine, time to phaco. Initially, I just go in with the Cortex settings just to remove all the overlying cortex and epinucleus. Time to emulsify. The strategy which I mentioned, initial strategy for me is to do a stop and chop technique. The modification which I've done at the tip is exposed a little bit longer. This helps me to give better access to the deeper part of the nucleus without the sleeve getting in between, and also hopefully I'll be able to create a more narrower trench which is going to help me to crack the nucleus in a better way. So that's the idea of using the longer tip. So these are the settings. As is customary, I'm using a 90% power. This is a balanced tip which I'm using in a Legion machine. The lens is stabilized with my second instrument as the trenching is begun. I'm going to be using lesser frequency. So initial thought of stop and chop. As I try to trench deeper and deeper, I feel that I need to go much more deeper, but I'm unable to go deep because the sleeve is obstructing it, and I don't want to make a very wide trench. So that's a situation where I decided that I'll go into do a 4-quadrant technique. When I do a 4-quadrant technique, I invariably have better access to go in much more deeper. I thought let's try and do the 4-quadrant technique. So in this density of nucleus, my goal is to have the trenches at least 90% depth. That was my goal. The principles are same. Stabilize the nucleus with the second instrument. It's very important, especially when you're dealing with such hard nucleus and a bag which is slightly wobbly. Remember that sculpting is a process where the nucleus has to be melted effortlessly, not pushing or shoving at it, as it's happening sometimes here because the tip is getting entangled in the nuclear fragments. So I'm just trying to change the angle and go in deeper. I'm just going to fast forward it here, play it in double speed so that we can cover this case in a little bit lesser time. The sculpting is continued, the nucleus is rotated, and the trenching is continued. All the 4 trenches are progressively deepened and deepened until I reach 90%. And it takes a while actually to get to that depth. Every time I feel this is good enough, then realize that once I rotate the nucleus, I feel that this trench is not so deep enough. So again, go in and repeat the trench. So eventually there comes a stage where I feel that the depth is good enough. It's about 90% depth, especially in the central part. And now is the time to go ahead and do the division of the nucleus. The chamber is refilled with OVD, and consciously I've chosen to use 2 long Sinskey hooks. In fact, one is a Sinskey hook and one is a chopper instead of phaco tip and a chopper. The idea was I would get a better reach to the base of these trenches so that I can then separate them with relative ease. I try to place them in one of the trenches and try to separate them laterally. At the first instance itself, I realized that, well, this is an ultra-hard cataract. The posterior plate is refusing to give way. Then I quickly shift positions and try to separate the other part. And a couple of attempts by consciously being mindful of placing these instruments as posterior as possible eventually gives up the first crack, and it's a full thickness through and through, but not the entire span of the nucleus. At least along the lines of 1 quadrant it is done. The nucleus is rotated now. I'm just trying to separate another fragment. The peripheral part is broken, but the central apical region is still attached. And at this stage, I thought it's really stressful to do this. The posterior capsule will be very thin, and I'm trying to separate this. It was really stressful. Not in the bag as such, but in my mind. The only secret here is trying to place these instruments as deep as possible. And many times we realize that when you try to do that, they just slip and come away. That's one thing, and you keep on persisting with it. The goal was to ensure that at least 1 fragment is free. Then we can pull it out and the rest can be dealt in an easier way because we have got more space within the bag. I repressurize the chamber with OVD and again go back with my 2 instruments and try to repeat the maneuvers. So I realized that the posterior plate separation is still partial. In majority of the fragments, the central apical region is still holding on. So what I realized is at least 1 fragment is free. So I'm using 2 instruments to gently maneuver that 1 fragment out. Time to phaco now. So we're going to the fragment removal mode. That is, I'm going to use continuous torsional energy to emulsify this big chunk of a nucleus. So at this point, you can see the CDE is already around 80. So it's significantly higher than most of my cases. And point which I want to highlight here is that look at the position of the nucleus in the phaco tip. So it is at the level of the pupil when it's going emulsification, and the second instrument is always on top of it, ensuring that some of the fragments which are going to fly around are minimized. And the phaco is being used in a very slow and judicious way, so to minimize the chatter. It's going to test a lot of patience. Emulsification of all these fragments can be finished in a matter of a couple of minutes itself if we use more energy, but that's going to be detrimental because it's going to increase the chatter and that is going to cause the mechanical damage to the corneal endothelium. So the only secret to have clearer cornea is to go slow and emulsify them at a slightly posterior plane. So once we are very judicious with the use of power, you can literally see that you can control the rate at which the fragments are emulsified, and it also minimizes the lens chatter. One fragment is out. Again, I'm going to replenish the eye with OVD. First, the dispersive OVD goes in, followed by HPMC underneath it. This is the modified soft shell technique. 3/4 of the nuclear fragments are still intact, and the posterior plate is partially broken among all the 3 fragments, but the central apical region is holding them together. So this is what we do is lift up the base and try to phaco that bridge which is holding on all these 3 fragments together. That's the most stress-free way of trying to prep the posterior plate. You're not going to do any lateral separation going deep within the bag, and those lateral separation maneuvers itself can result in PC tear. So this is the secret to break the ultra hard posterior plates. So what we do is we create some space by removing one piece, and then all the remaining fragments, they're just maneuvered so that the apex, which has the bridge which is connecting all the 3 fragments together, is exposed up. And then using phaco power, I'm going to use the continuous torsional energy just to go in and nibble at these bridges, and lo and behold, all the 3 fragments would be quite easily separated. So lift up the nucleus and phaco the base. That is where the bridges are holding the posterior plates of these 3 fragments together. And in a very effortless and a stress-free manner, we're able to separate all the 3 fragments. And once the 3 pieces are separate, again it's mandatory that we push them back into the bag and then pull them out and emulsify them one at a time. So after the emulsification of the first remaining nuclear fragment, again OVD goes in. The unwritten rule in my head is that after every fragment I'm going to inject OVD, that is the modified soft shell technique. And in this case, by the time it gets completed, I would have used 2 syringes of dispersive OVD and 1 syringe of HPMC. So dispersive OVD which I'm using here is Orolab, but there's no financial interest. That's what I have used in this case. So never be miserly in the use of OVD. There's nothing more expensive than the endothelium. So take every possible measure to safeguard your endothelium. Again, the emulsification is very slow in a posterior plane and in a controlled manner, and the fragment is eventually emulsified. The toughest part of the surgery is over. My assistant has just displayed the event screen here on the machine, and we can see that the energy consumed is 120 CDE, and this is the amount of fluid which is used during the surgery. A time to remove the cortex. As I tried to go ahead and do cortex aspiration, I realized that there's a lot of lens particles in the burger space, and this is a clear indication that there is a high risk of fluid misdirection in this particular case scenario. So I would want to postpone the cortex aspiration, and before that, so I want to use the CTR now. The bag is inflated with OVD and the CTR is placed into the bag. The idea being, I think that by using a CTR is going to stretch the bag a little bit, and by doing so, I'm hopeful that the chances of fluid misdirection are slightly minimized, because maybe it will improve the zonular barrier effect. I'm not sure about it, but this is what I want to do it now. So once the CTR is in the bag, I have decided to go in and place the lens also now, and then attempt cortex aspiration. Because I want the cortex is only the peripheral part of it, so I prefer to deal with it later. The lens is in place now, time to remove the cortex. Mind you, at this stage, usually we go ahead and remove the BX device. Now because the cortex is in the peripheral part, I would continue to use the pupil expansion device until I get rid of the cortical matter, and remove the OVD from behind the lens, And then if the need be, I would want to reflate the chamber with OVD, remove the BX and then remove the OVD. That's the plan. So removing the cortex is slightly tricky because in these hypermature cataract, it's a very flimsy, thin fiber lac and it will be very much adherent to the capsular bag. So we need to be very careful that we're not pulling out the bag at this moment. Although the CTR is in place and it can hinder in the cortical extraction, but nevertheless, if we are a little bit persistent and do some tangential movements, eventually the cortical fibers are freed and then we can aspirate it out. The OVD which is behind the lens is again irrigated out using the irrigation handpiece itself. Some of these small fibers are really irritating and frustrating. They don't come very easily. They just keep on giving you a glimpse and you're not happy. You go back and try to remove it and they don't get engaged very well in the port. So nevertheless, again, the rule is persist with it and eventually you'll be successful. So thankfully all the cortex is taken care of and all the OVD is also taken care of. So in these eyes where the antechamber is very shallow, I wouldn't prefer to remove the BX ring with the irrigation cannula itself. We can do that, but sometimes it can end up in some complications. So especially in these eyes where the chamber is very shallow. So the visco goes in, the notches are disengaged, the BX ring is then pulled out. The remaining OVD is irrigated out, the side ports are hydrated. That's it, the case is done. At this point, you can just see the multiple tiny fragments in the retrolental space, which are very visible across the red glow. These are fine lens dust particles, and these are the telltale evidence of the loss of the zonular barrier, and that's the reason why we see these lens dust particles in the Berger space. So finally, the case is done. So lots of learnings from this case. If I have to summarize, well, this was a case I shouldn't have done phaco. I have told it any number of times. It's the mechanical energy and the plane of energy at which it is delivered, which is more detrimental to the endothelium rather than using this. So here, the majority of the energy was used within the bag, far away from the endothelium and during sculpting. And the plane of emulsification of these fragments are also much more posterior. So if you're cautious of this and also use the OVD as much as you can at every step, then you'll be pretty sure that the cornea would be pretty good the next post-op day. Having said all these things, if I had a second chance, well, in this case, I would have thought doing manual small incision cataract surgery would be much more better for most surgeons, including me. Without being very humble, I can tell you, there are many moments in the surgery where I sincerely felt that I should have not chosen phaco, I should have done the manual SICS in this patient. Because especially when you're trying to separate these thick leathery fibers way deep in the bag, and these are the moments when I really thought that why am I doing phaco in this patient? So definitely you're stressing so much for not only on the capsular bag, but more importantly, the stress the surgeon undergoes is quite immense. So I must confess that I had more than a couple of times had this thought that, well, this was not the case to do phaco emulsification. Nevertheless, if you had to choose, then follow all these principles. A second thing would be, so I thought the pupillary dilatation, if it was much more bigger, the stress levels would be much more lesser. That's what I feel. So these were some of the thoughts which I had, and nevertheless, decision making is extremely important. Before I end, I want to share a video which I had done many years back, like, how choosing safer surgery is much more important. I can really re-suggest that video after doing this case. It's really worthwhile to go ahead and watch that video. So thank you for watching and hope you found this helpful.